We are living in the age of evidence-based medicine, and so when we are talking about the prophylaxis in our patients with hemophilia or in our persons with hemophilia, we should know what is the evidence supporting such a treatment. Surprisingly, despite of the fact that the prophylaxis is in use for over 40 years, the evidence is not that high. Regarding pediatric population, there are some published expert opinions and consensus statements, like you can see on the slide. There are several retrospective, often non-controlled studies, and recently there was the first prospective randomized multicenter open-label trial focused on the benefits of prophylaxis in children with severe hemophilia. In adults, there is even less of evidence. Again, several retrospective non-controlled studies, reviews, and recently one multicenter open-label cohort study. So we will focus on those two which are on the highest level of evidence. So let's start with children. This is some sort of flow chart or the study design of joint study, the open-label randomized multicenter study conducted from 1996 to 2006 and by Michael Johnson and co-workers, and radiologists, physiotherapists and lab technicians were unaware of the patient's treatment status. There were 65 children with severe hemophilia A aged 6 to 3 months who were enrolled into the study and randomized into two groups, the prophylaxis group and enhanced on-demand treatment group. The prophylaxis group, concerning of 32 patients, was given the prophylaxis of 25 units per kg every other day. When there was bleeding, apart from prophylaxis, they were given 40 units per kg immediately, and again, there was further resumed prophylactic infusions scheduled the next day. Those who were in the enhanced on-demand treatment group were given no routine infusions. However, when bleeding, they were given 40 units per kg immediately and followed by 20 units per kg at 24 and 72 hours, and then every other day until complete resolution up to 4 weeks. So from that you can very easily see that it was really enhanced on-demand treatment, not the standard, but really enhanced on-demand treatment. In the end of the study, the major outcome was the MRI and X-ray evaluation of the joints at 6 years of age, and 6 major joints, ankles, knees, and elbows, were evaluated. So what was the result of that study? The study is saying to us that there was less bleeding episodes in boys with prophylaxis compared to boys with enhanced episodic on-demand treatment. You can see it here in the different time points: 1 year, 2 years, 3 years, 4 years, and 5 years. And you can very easily see here that the number of joint bleeds was just 0.2 per year on prophylaxis versus 4.35 per year on episodic treatment. And if you count total bleeds, the difference was even higher, around one bleed per year on prophylaxis versus 17 or over 17 on episodic treatment. What the study showed was also that the prophylaxis was associated with significantly less joint damage than on-demand treatment in children at the age of 6 years. You can see here the graph with the MRI findings. The bigger the bubble is, the more patients are with the certain MRI scoring, and the higher the score is, the worse is the outcome, the worse the joints are. And you can see from the study that the joint damage was present only in 7% of children were on prophylaxis versus 45% of those who were on demand treatment. This reduction was thus about 83%, and the difference was statistically significant. What was quite surprising was there was poor correlation of MRI scoring with either radiological score or with number of hemarthrosis recording in the patient's diary. The reason for that is very likely that the MRI scoring is much more sensitive, or MRI imaging is much more sensitive to microhemorrhage into joints or subchondral bone than the traditional radiological or clinical scores. Again, just shown on slide, how significant was the reduction of the joint damage in children on prophylaxis compared to those on demand treatment. From that study, in fact, we can say that what Swedish treaters and other treaters who are using a prophylactic treatment in pediatric patients with hemophilia know for many years, that this finding has been proven on a very high level of evidence. Now switch from the children to adults. So what are the main benefits of prophylaxis in adults? This is a study by Collins, and what he did was that he enrolled in his study the patients who were aged 30 to 45 years with severe hemophilia and who were bleeding quite frequently, so over 20 total bleeds per year. The endpoints were the number of bleeds during prophylaxis versus on-demand treatment. So in the beginning of the study, when the patients were enrolled, they were for 6 months on-demand treatment. Then there was a month of stabilization being switched to the prophylactic treatment, and then another 6 months of prophylaxis with 20 to 40 units per kg 3 times per week. You can see on that table that the number of patients in those two groups was similar, and the number of bleeding episodes per the period was significantly different, with median of 15 in on-demand group and median of 0 in prophylactic group. The difference was statistically significant. If you annualize the bleedings, because both of those periods were just 6 months, so if you annualize the bleeding rates, you can see that there is a significant decrease in spontaneous bleeds per year as well as in trauma bleeds per year. If you compare those two groups from the point of the factor 8 used, you can see that the dose per injection was not significantly different. The dose per week, there was a significant difference because it was administered much frequently. So you can see roughly the 3 times higher dose used per week, and it corresponds with the dose per year, which was again roughly 3 times higher when you compare the on-demand treatment to prophylactic treatment. What was the result of the study was that the secondary prophylaxis in adults significantly reduced bleeding rates, though there was a wide interpatient variability, partly due to target joints and trough levels, which were different in different patients. Gilbert's score was decreased mainly because of the decreased bleeding, number of bleeding episodes, and less pain. There was no change in quality of life and in health economics. though the factor VIII consumption increased. This study does not answer the question, what is the long-term effect on joints, or the long-term effect of the temporary prophylaxis on joints, but it was not the intentional endpoint of that study. However, talking about the prophylaxis in adults, one question has to come in mind, that when, if at all, to stop prophylaxis in patients with hemophilia, because we know that it is very efficient in children. We know that there is a certain effect in patients, in adult patients, mainly in those who bleed frequently. So when, if at all, to stop prophylaxis in patients with hemophilia? Currently, it is uncertain whether to stop or continue the primary prophylaxis once adulthood is reached. So far, there is no satisfactory method, and this is quite important, for selecting patients for continued prophylaxis, because some adults will bleed infrequently even without prophylaxis, and on the other hand, some will suffer progressive arthropathy. On the other hand, it seems there is increasing evidence showing clinical benefit of prophylaxis in adulthood, either continuing from childhood or reintroduced. And though cost effectiveness is more difficult to sustain in adults than in children, it seems that the increased costs of prophylaxis are counterbalanced by indirect factors.